Thank you so much for being here this morning. It's a true honor to follow Dr. Farmer. Particularly, thank you for highlighting the topic of my talk today. And so I'd like to start off as a brief review. Let's see if this will work. There we go. If you're not familiar, hepatitis C is the most common bloodborne illness in the United States, and there's about a 1% prevalence across the U.S. But it is much, much more common in certain vulnerable populations, including people who have been incarcerated, as well as people who are experiencing homelessness. And at Boston Healthcare for the Homeless program, we have a 23% prevalence rate. That means 1 in 4 or 1 in 5 of the patients we take care of, in addition to living in a shelter, trying to gain housing, dealing with a myriad of other health issues that are also living with hepatitis C. And that prevalence rate bears out across other healthcare for the homeless programs across the country. And unfortunately, up until this point, we haven't had a clear, coordinated response about how to deal with that. Hepatitis C affects the liver specifically, and over time can cause cirrhosis, which can lead to liver cancer or end-stage liver disease. And the rates of end-stage liver disease and liver cancer are increasing and at an alarming rate, and are expected to peak by 2020. And this contributes to not only significant healthcare costs, hospitalization rates, and significant mortality. In our own data, we believe about 10% of our mortality is associated with liver cause. But it also is incredibly hard to manage in a homeless healthcare setting. So we're taking care of decompensated cirrhotics in our medical respite facility all the time, as well as in the shelter and on the street. And it's been a significant challenge and something that we've all of our primary care providers face on a daily basis. Truly, our primary care providers are really liver experts. And the kicker is that it's a curable infection. So hepatitis C it's been tough to cure for so many reasons, not the least of which is that the therapy that we've had for so long is very toxic. It takes up to 48 weeks, has cure rates less than 50%, and in some populations as low as 20%. And really the toxicities are akin to chemotherapy. It's been very hard to implement those types of treatments in vulnerable populations who face a lot of other challenges. But there are also a lot of other barriers, including access to care at all, access to screening and diagnosis, as well as attitudes. So patients have a 20-year history of hearing about people going through these very difficult treatments and not wanting to do that themselves, but also may have a perception that their livers are healthy because they don't have any symptoms. There's also challenges around competing priorities that all of us face. Of course, deciding to do a year of treatment that's very toxic is hard for anybody to do, not the least of which in people who are also homeless. And then access to hepatitis C treaters who really know what they're doing. It's a very narrow pipeline. So we're incredibly fortunate at this point in time to be facing this brand new opportunity. And the pace of drug development in the last few years has we've discovered a couple of new medications and many more coming that are significantly more tolerable. They're shorter, as short as 12 weeks. They improve the cure rates up to 90% and are all oral medications. Later this year, we really expect interferon to be gone for good. And I think for populations like ours, we're really at the brink of a total game change in the way that we're able to respond to this. And the thing is that when you cure hepatitis C, it actually really makes a difference. So all-cause mortality rates go down, rates of liver cancer and rates of decompensated cirrhosis requiring liver transplantation all go down when you cure. And so in the Kraft Practitioner program in the last 2 years, what we've been trying to consider and really think about is what is the best way to address this in our population? And with my mentor, Dr. Gaeta, as well as our Kraft mentors, we really decided to come at this from a couple of different angles. And one is that we truly needed to understand what our patients wanted and needed. Were they able to consider this at all in the scope of all of the other challenges that they face? What were the barriers that they perceived walking in? And what were the things that they felt like they were going to need to go through treatment? We also needed to give our primary care providers the tools to provide the most excellent level, most up-to-date level of care with all of these major changes. And then we needed to understand what our capacity was to really incorporate treatment within our primary care center. And there have been models of doing primary care treatment of hepatitis C for a while, but only in the last couple of years has that been more appreciated as a way to impact the cascade of care. So the first thing we did a patient needs assessment survey. It was a 32-item self-administered questionnaire that was available in English and Spanish at 4 of our clinical sites. We administered this at our main clinic site at Jean Yaki Place, as well as our medical respite, the Barbara McGinnis House, and then 2 shelter-based clinics at Pine Street Inn and St. Francis House. And we were so fortunate through the collaboration and participation of our staff to get 240 respondents to our survey. And I would love to talk about data more later during the poster session if you're available. But to summarize, first off, this was the first needs assessment that has been done in the homeless healthcare setting around hepatitis C. And we found some really exciting things. That one, our patients have actually a very good knowledge level about their hepatitis C. And that actually 86% of them are interested in doing hep C treatment. And 74% are confident that they could complete it, which was, I thought, truly astounding. And that bore out across the diversity of housing status, diversity of experience with drugs and alcohol, as well as racial and ethnic breakdowns. And then the other really encouraging thing was this theme that kind of ran through, that the role of the primary care provider was truly central to our patients, that they found them to be significant in terms of education, as well as motivating people to consider treatment, and that the primary care center was the preferred site for hepatitis C treatment. Which then led us to work on some primary care guidelines. And my main goal with this was to be able to translate the extremely exciting, most innovative things happening at the specialty level and make them available to our primary care providers who are caring for these patients in shelters or on the street or in our main clinic and may not have the ability to get schooled up on these great changes themselves. And so this resulted in the production of 2 documents. One was a front and back one-page quick reference guide for primary care providers, and then a longer protocol summary document to be available to all of our providers through our electronic medical record. So we have actually integrated that just recently, which is very exciting. And these guidelines and the study were recently presented at the National Healthcare for the Homeless Conference, and the documents were kind of snapped up and by our partners across the country, which was also very, very exciting. And the primary care documents, one of the new concepts that was very exciting to bring to our community was not only talking about screening and how to monitor people who are living with hepatitis C, but also how to assess their liver fibrosis, which, if you're familiar with hepatitis C at all or cirrhosis management at all, is a just incredibly complicated and tough thing to do, and has traditionally been based in liver biopsies and really in the specialty office. And that's just not practical for our patients. And so one of the things that we added was the integration, it's really raining, of a non-invasive liver fibrosis marker that can be applied in a population management approach through our electronic medical record, so that we can figure out who our sickest patients are with cirrhosis and highlight their need for additional screening and evaluation for things like liver cancer, but also really prioritize them for treatment. They are going to be the ones who are going to be the sickest the soonest. And so we really need to identify them wherever they are, even if they're not coming in. We can use this equation across our medical record. And this is don't get mired in the details, but it's a screenshot from the one-page document we have primary cares utilizing for that fibrosis assessment and cirrhosis management. And the calculation that we use is actually integrated into our electronic medical record. And then the last aspect, which I think is so exciting, and I'm sort of the most proud of, is that we've started doing treatment within our health center. We developed a consult service led by myself and a physician and a nurse that we work with to have other primary cares can refer patients to us, and we will evaluate them for treatment. In some cases, we're deferring them until other treatment strategies are out later this year or in the future, or they're very healthy now and they don't need treatment at this moment. But there are other people who are actually quite sick and have been waiting for treatment for years and years and years and not being able to take advantage of the prior treatments for a myriad of reasons. And so thus far, we've seen over 50 patients. We've treated 7. All of our patients who have gone through treatment thus far have achieved undetectable viral loads within the first 4 weeks of treatment. And I wanted to pause here and think a little bit about, there's a patient who, Dr. O'Connell couldn't be here today, but he and I were talking. In 2001, he was a street team patient. He was outside and he was using heroin, and he actually, they saved him from an overdose. And from 2001 to now, he has gotten clean, he's gotten housed, He's actually gone through a substance abuse education training program so that he can counsel others. And as of Monday, I was able to tell him that his hepatitis C is gone. It's incredibly encouraging work, and work that I think our health center is really well poised to do, and we never had the tools to do it before. And so I thank you so much to the Kraft program to be able to work and develop these tools and start to implement our work. There's so many people I'd love to thank. There's only a few of them, but particularly the staff and the patients at Healthcare for the Homeless and the Kraft program for being able to help us launch this program. I'm also excited that we have a plan to continue this program after the Kraft, the practitioner time ends, and we've applied for additional grant funding to be able to expand it. So thank you very much.